Welcome to Make America Healthy Again. Join Dr. Charles Antinori and friends as they share solutions, tips, and insights that only doctors know for creating better health. Here's Dr. Antinori.
This is Dr. Charles Antinori, and today we're talking about dieting and modern medicine. And our guest is Dr. Bud Waisbren, an internist and cardiologist who's been practicing for a long time. He did his training up in Boston at Tufts and then down in New York City at Cornell, and has been practicing in our area. We shared an office for a while, for about the last 40 or 50 years. So today we're going to talk about dieting and possibly some other topics. So, Bud, I want to just have you start off and say, what are the strategies you have for losing weight?
Well, as you know, Charles, I'm a cardiologist, and in general, we try to limit the number of cardiac risk factors that patients have. The most serious risk factors are smoking and diabetes and old age, but obesity is a major risk factor, and a huge number of Americans are suffering from it. So generally, we start with a recommendation of diet and exercise. The truth is, however, that exercise doesn't really do it. If one is on a treadmill for a half hour, it's only around 30 calories. So, and the only thin athletes are the marathon runners and the bicycle racers. So, exercise is good for a lot of reasons, but it's not going to solve the obesity problem. The best diet is the high protein diet, and by high protein, I essentially mean no carbohydrates. And the reason it's so effective has to do with insulin, not calories. When someone eats a meal, no matter what they eat, after digestion and absorption by the body, it turns into glucose, which is the primary source of energy for the cells of the body. But the glucose that is in the bloodstream doesn't get into the cells unless a hormone, insulin, puts it there. Insulin is made in the pancreas. But importantly, insulin is not released from the pancreas into the blood unless one eats a carbohydrate. So typically, let's say you eat a steak and a potato. They both get digested. They both turn into glucose in the bloodstream. But because you ate the carbohydrate, the potato, insulin is released, and that pushes the glucose into the cell for metabolism. Now, if someone eats just a protein, let's say a steak and no potato, it gets digested. It is in the bloodstream in the form of glucose. But because there's no insulin, there's no carbohydrate to put the insulin in the blood, that glucose stays in the blood and does not get transported into the cell for metabolism. Now, the body has to have some form of substrate, some form of energy to maintain one's body temperature and other vital functions. So the body goes into Plan B, and Plan B is to mobilize fat stores as a source of energy. And the metabolic byproduct of fat metabolism are ketones, and that's why they call it a keto diet. The big challenge, however, is that you really have to avoid carbohydrates, because even one cookie will ruin the ketogenic diet because that's enough to stimulate the pancreas. I have a patient who's a competitive bodybuilder, a woman who poses and has zero body fat, and all she eats is ground turkey, 3 meals a day. That's all she eats. And because of that, she has no insulin released, and she's able to have no fat stores. Failing that, and a lot of people just can't succeed at a diet. Then there's Weight Watchers and Nutrisystems, things like that, and they do work if you do it.
Yeah, let me just interject for a second, but about, again, it's anecdotal, but our mutual friend and your patient gained a lot of weight after she went through menopause, and then you put her on the high-protein diet, and God, she must have lost 30 or 40 pounds without, I mean, she's an active girl, so she did some exercise and everything, but by and large, it really was amazing. You know, she had gained like 30 or 40 pounds over, 6-month period, and she lost it over like a 3 or 4 month period. It was really unbelievable. It works.
That was anecdotally also. I had a patient who was an insulin-dependent diabetic, so he was incapable of making his own insulin. So he was really dependent on his insulin shots, and he weighed around, must have weighed 500 pounds. And he came into my office about 10 years ago, and said, Dr. Waisbren, I'm sick of medicines, I'm sick of insulin, I'm sick of you, I'm stopping everything. And I said, you can't do that, you're on insulin. But he stormed out of the office and returned a month later and had lost around 70 or 80 pounds. He had been eating the whole time, but his blood sugar was very high, his blood glucose was very high. But because he had no insulin, it couldn't get into the cell, so he just mobilized his fat stores. So then, again, after diet,
it's almost like an Atkins-type diet, too. It's like
absolutely.
Internal
it does work.
Yeah.
It does work.
Yeah.
And if you do that, if you go that route, you have to drink a lot of water to flush out the ketones.
Right.
Because they are toxic. Then there's traditional diet pills like phentermine. Phentermine is actually very safe. It's an amphetamine. But like all amphetamines, it is habit forming if you take high doses for long periods of time.
Right.
But if you take it responsibly, you can lose around 6 pounds a month. We sometimes pair that with topiramate, which adds to the efficacy of it. And the advantage of phentermine and Topamax is that it's very inexpensive. So even if insurance doesn't cover it, it's only a few dollars a week.
Yeah.
And it works by just killing your appetite. And then, of course, everyone is interested in these new diabetic drugs like Ozempic and Wygovy.
Right.
Which it really kills the appetite. The way they work is they get you almost nauseated, so that the idea of eating is just repulsive.
Right.
One has to start with a very low dose, and the body gets used to it, so you have to increase it incrementally. Initially, it was very expensive. It was $1,500 a month.
Yeah.
And the insurance did not cover it initially. But now everything's changed, and the reason is not what you'd expect. Someone did a study of people over 65 who were not diabetic and not obese and gave them Wygovy and found that they had a far lower incidence of heart attacks and strokes.
Yeah, right. I read that, yes.
So the government passed a rule that if someone has Medicare with a drug policy, Medicare has to cover Wygovy, not for weight loss, but for cardiac protective effect.
Wow.
So a lot of the older patients are now going on Wygovy because of that ruling. And,
it's funny. Just within the last week, I saw an article in the New England Journal, and they looked at the fatty liver, and a lot of people on I forget which of the semaglutides he was on, but the people in the group were on, in the study were on. But their liver, they did CAT scans on them, and their fatty liver got better, and without becoming fibrotic and everything. It was because it's unbelievable. I know you see the CAT scans nowadays. That every other CAT scan they read is steatohepatosis, fatty liver basity, and that we know that's sort of a precursor to cirrhosis and to hepatocellular carcinoma and everything else. So it really is amazing that these pills or these shots. I guess right now are they pills yet, Bud?
No, there have been pills that work the same way, but for some reason they don't work as well as for weight loss. There's something about the shots. I don't know. Maybe it's the dosing. I just don't know why the shots work so well.
Right. I see mostly they're talking about the shots. And what do you think of these other ways of getting it for people that aren't like Medicare? They can't get it from their, I see this, it's commercials on TV all the time talking about, people that can get you these drugs for like HERS, I think it's called, or something like that, and, where you can get them supposedly a lot cheaper. What is the going rate now for say, Wygovy for a month for the average patient that's using it? $500 or something like that?
If you don't have insurance, it's $1,500 a month.
It's still like $1,500 a month, huh?
Yeah.
I think these are. Again, I don't know the details of these advertisements. They're just the kind of things that come up every commercial during the baseball games and stuff, And they make it sound like they're getting you this stuff a lot cheaper than. But that's not a big factor yet, as far as you're concerned, huh?
Yeah. Well, what happened was during COVID especially, there's a law that says that if there's a supply limit to a new drug, even though it has a patent, if there's a supply problem, then one can make it and sell it without worrying about a patent infringement lawsuit.
Oh, I see.
but now supposedly the supply problem is over. So I don't know how much longer these companies are going to be able to do that.
Right.
And there's also some concern about counterfeit weight loss medicines and.
Right.
So I just don't know enough about these products. I don't prescribe them.
Right, but other than getting them from the normal channels, right? Yes, one of the other conferences. My brother is going to do a podcast, and he's worked for one of these orphan drug. He's worked for 2 separate orphan drug companies. It's very interesting what they go through trying to get the drugs and how long the patent can hold and all that sort of thing. It's a really another hugely complicated section of business, the medical field. People I don't know realize how complicated this is and how much money it costs to develop these drugs.
Oh, it's unbelievable. The cost to develop a new pharmaceutical is in the millions.
Yeah.
And patent, I think, only lasts around 7 years. So.
Right, I was surprised. It's only like 7 years that they're protected. It really is hard to make because it probably takes a few years to get the public aware of a drug. You know what I mean?
Sure.
You really have a fair. I was surprised that it is only 7 years. I was very surprised.
Yeah.
I just talked to him a couple of weeks ago about this, and one of these days we're going to do a podcast. But the other thing we said we were wanted to talk about for the audience and everything is talk about what you think is not right or what's wrong with American medicine right now.
Well, if you had 10 hours for this podcast, I could tell you.
Right. We only got about another 10, 12 minutes.
Right. But the problem is money. What's happened is corporate America has discovered medical providers instead of physicians. And when a hospital, for instance, hires a nurse practitioner, it costs around a quarter of what it would cost to hire a real doctor.
Yeah.
And the public, for some reason, thinks that if it goes to a clinic and sees a nurse practitioner, that's equivalent to seeing a physician. The reality is they couldn't be farther apart. Although the law is that a nurse practitioner has to be closely supervised, in my experience, they're never supervised, ever.
Yeah.
And they are not trained in pharmacology or anatomy or anything else. They have a couple of years of a classroom, and it's a travesty, I think. And what's even worse are the physician's assistants, who sometimes don't even have a college degree, and they see patients and recommend surgery and so on without supervision. And it's just decimated the quality of care in this country.
Yeah.
The other problem is the insurance reimbursement for doctors is so low that physicians cannot afford to go into private practice.
Right.
So they're forced to work for clinics owned by big business or by hospitals, and these are the same folks who hire the nurse practitioners and the physician's assistants. And hire as few doctors as possible.
It's very clear. Again, I talk about it in the book, but how the reimbursement dropped. I mean, speaking about cardiac surgery, a good example, back in the 1980s, your basic coronary artery bypass times 3, we used to get like Medicare, which was a middle-of-the-line payer back then. It's now your best payer, but it was one of your best payers. And back then, Medicare for a coronary bypass times 3, the most common cardiac operation, we used to get paid $4,600 from Medicare. And, by the time you put the assistance and everything in like that, it was over, it was more like close to $5,000-$6,000 for a procedure. Now, what are we talking, 40-something years later, they're paying like $2,300 for the operation. I mean, it's.
Well, I've got another story to tell you.
Yeah.
When again, I'm just an internist cardiologist, but in 1977, when I first went into practice, that was a long time ago.
Yeah.
If I did an EKG, the insurance would pay about $42.
Yeah.
Now when I do an EKG in the office, I get $12.
Right. And that's the EKG machine and printing it and reading it and everything. It's just unbelievable. Yeah.
So you can see why physicians just don't go into practice anymore.
Yeah, we could talk about this for people for hours, but
sure.
Really all the things that pushed it were it was a trend that was started, but what really, in my mind, at least like in my case, one of the reasons I ended up becoming an employed physician for the last 10, 12 years of my career was the Obamacare, which I could tell was going to just be a giant expansion of Medicaid. And, we're talking about how bad the reimbursement is for everything. The reimbursement for Medicaid is a fraction of that. It's almost non. You could be extremely busy, and you'd go bankrupt if you only had Medicaid patients.
Sure.
And then the computers. When they passed the High Tech Act, where everybody had to buy a computer, and wasn't even just the initial cost of the computers and everything. It's like a constant maintenance, and a high level
sure.
maintenance. You remember when we worked at Cape Regional, when I started there, and probably around the time you were there, the first couple of years you were there, I'm sure that they had like 2 or 3 people with a whole IT department. And now I don't know how many have it at Cape Regional, but at Vineland, it's the biggest department in the hospital. At a lot of hospitals, it's become the biggest department in the hospital.
The other travesty is the computerized medical record, which any doctor will tell you contains totally useless boilerplate information.
Repeated boilerplate over and over again.
So to get reimbursed by the insurance companies, you have to create this volume of paper that's totally useless.
Right,
so
right. They give you these templates where it just, and then they just put everything into every note. You write a routine progress note about somebody where you want to make one comment like doing well, took clear liquids or something. That's all that really happened that day, and you print it's a 2-page note because it puts in automatically every X-ray they had that day, physical exam. And I get a kick out of the physical exams. If people have these template physical exams, they don't even look at the patient anymore. It's embarrassing, like the template. If they miss things like a colostomy, stuff like that. It's really
the whole system is so corrupt, so fraudulent. It's just it's a tragedy. And when you and I were trained, there was a lot of dignity in being a doctor.
Right.
We were proud of our work product. We were proud of our relationship with our colleagues, and we received respect from the hospitals. That's all changed now, and the kind of person going into medicine is very different than the kind of person who went into medicine when we were.
Absolutely. Yeah. We talk about. I went to high school Regis in Manhattan, where Tony Fauci went, and a lot of guys used to go into medicine. It was considered one of the better things you could go into. Now, they're all really smart kids, and the majority of them are going into finance or something, research or something. But they're not going into medicine,
Sure. So the last thing I want to really emphasize is the responsibility of the patients and the fault of the patients. The average patient has opted to look for the most inexpensive insurance policy they could possibly find, which often is an HMO, either a Medicare Advantage plan or some other health plan. And these insurance companies profit by placing barriers between the patient and the doctor, requiring pre-authorization for studies that are absolutely necessary. And what happens is the physicians end up just providing substandard care for patients who have that kind of insurance policy. And I think patients that they're willing to pay their lawyers, they pay their accountant. They've got to be willing to pay their doctor and buy a good health insurance policy. Otherwise, they're going to suffer. And I see this all the time.
It really is true. And it's funny. Right now, as I said before, Medicare is probably your best payer. Most of the other insurers kind of spin off Medicare. I mean, once in a while they'll tell you that they're going to pay you a little bit more than Medicare pays, but Medicare is going. I think Dr. Oz believes that we should go toward that Medicare Advantage, but I've seen other articles that were saying that Medicare Advantage is basically kind of existing based on the people that it's been subsidized by the people that are paying for full Medicare, which is what I always tell people to go on, because that's what I was always advised to go on in my entire career by the girls that work in the office that do the billing, Medicare and have a good supplement, and now you pretty much have to have Part D as well. But these Medicare Advantage plans are much cheaper than Medicare Supplement and Part D. And so the people are jumping on it, but they don't realize that when they go out of network, it's a problem. Whereas with straight Medicare, you can go anywhere in the United States, and I think even in foreign countries, they'll cover you. Well, anyway, Bud, we've been past 20 minutes here. Really great talking to you. I think our audience will probably appreciate this, and like I said, we probably should do it again at some point in this cycle.
All right, be happy to. Well, good talking to you, Charles.
Same here. Thanks, Bud. Bye.